Okay, so with subarachnoid hemorrhage, again, worst headache of my life, it's usually due to a burst aneurysm or AV malformation. And there's a genetic component to that. It can run in families. These are the causes. Trauma and stroke is kind of what we'll be talking about. But the berry aneurysm, that happens in polycystic kidney disease. So if somebody has a subarachnoid symptom, they're going to have those meningeal signs. Okay. Anytime blood gets into the cerebral spinal fluid, it irritates the brain. Okay. So the patient's going to have headache, photophobia. They'll have, the decreasing LOC. They could have projectile vomiting, and then you'll, assess them for any kind of deficits. Nuchal rigidity, which is a stiff neck, is also seen in subarachnoid hemorrhage or anybody that has blood on the brain. And then they could have seizures, so they're going to need seizure precautions and possibly like phenytonin. And they can get these things either clipped or coil in interventional radiology. Okay, with brain bleed, subarachnoid hemorrhage, they're going to be at risk for rebleed in 7 to 10 days. They're going to need nimodipine. It's a calcium channel blocker that crosses the blood-brain barrier. Okay, it relaxes smooth muscle and results in vasodilation. So it dilates like the arteries in the vein. And then with subarachnoid hemorrhage, you want to make sure you're giving them something for pain and nausea. So basically, I think you guys learned about meningitis and MedSurg 1. You know how you have to keep them like really quiet because you don't want them to have increased intracranial pressure. It's the same kind of thing. You never want them to like cough, sneeze, retch, so you need to make sure that they're on medications to prevent those things.
Okay.
And then with health promotion, I mean, nobody should smoke. You should eat right, drink lightly, exercise. For women, remember that estrogen increases the risk of stroke. Cocaine increases your chances of having a stroke, and maintain proper weight. And then I think you already know the warning signs, right? The be fast, sudden confusion, trouble speaking, numbness or weakness, slurred speech when you haven't been drinking, dizziness, all those things are risk, let you know that the patient might be having a stroke.
Okay.
We talked about this, the assessment, the timing, that's really important. We talked about the tests that you're going to need to know, the MRI, the nursing implications for that. Never, you can't perform an LP on somebody with increased intracranial pressure. Okay, so we're going to talk about right CVA versus left CVA. When I say CVA, I mean cerebral vascular accident. So the reason I say that is that's what we used to call it. And so I started saying right stroke, and people were like, what are you talking about? Because they thought I was talking about the side of the body. But so a right hemorrhagic or ischemic stroke in the brain is going to make the left side weak. Okay, so they are going to be paralyzed or they'll have hemiplegia on the left side. They'll have left sided neglect. Now, you kind of have to know the difference between right and left. If somebody's had a right cerebral stroke, they're going to have problems with sensory perception. They're going to be fall risks. And if you can remember, they're not right in the head. They get really inappropriate. They don't recognize their family's faces. They can get really, like become a compulsive gambler. They can do like weird things. They confabulate because they can't remember what happened. And then if somebody had a left-sided stroke, they're the ones that are going to be prone to aphasia, okay? And they'll have a weakness on the right side and maybe hemiplegia. So they'll have aphasia. Either they can't speak or they can't or they can speak, but they can't understand you. So one of those two things. And they're the ones that have all the A things like aphasia, agraphia, which means they can't write, or alexia. Um, so all those kind of things happens to people with left-sided strokes. Um, so what ATI will do is they'll tell you like, hey, you're taking care of a patient who had a right cerebral stroke, and they'll ask you about things like where should the rail be in the bathroom, right? So you have to think to yourself, if they had a right-sided cerebral stroke, that means the left side of their body is weak, right? So you want it on the right side where they can, grip onto it. So just remember those kind of things. And then it can cause what's called hemianopsia. Okay, and so that means it could either be blindness on like the same side here, or the same side of the eye. Okay, really, you could drive yourself crazy trying to learn all the variations of this. What you need to know is you need to put things in the patient's view, and make sure they're safe, and tell them to scan their environment. Okay. Um, so if you have somebody with right hemiopsia, you want to approach from the left side and put their belongings on the right side. That's what you would do with them. Now you're going to have to know the contraindications for fibrinolytic therapy. So we talked about you need to get the CAT scan first to rule out hemorrhagic stroke, because this is only for ischemic strokes. So you have to make sure the symptoms occurred within the last 4 to 4.5 hours. You mix it with sterile water, and you're going to, once the patient gets it, you're going to watch their deficits get better. Okay, so whatever neurological condition they had, like if they had trouble swallowing, hopefully it's going to get better when they get this. Anybody with a blood pressure, with a systolic blood pressure greater than 80 or a diastolic greater than 110 cannot get fibrinolytic therapy. But what they'll do is they'll give labetalol or nicardipine to bring the blood pressure down to at least 150. They don't like it to go so low, but they'll bring it down to 150. Okay. You cannot have alteplase if you have a history of a brain bleed or a brain tumor, if you have a dissecting aorta, if you have had spine surgery within the last 2 months, TBI within the last 3 months, ischemic stroke, except for the one you're having now, within the last 3 months. Platelets less than 100, in surgery less than 2 weeks. Okay, you cannot get that. They must go to the ICU. They must have frequent vital signs when they're on it, and we are going to monitor for bleeding, obviously. And then at 24 hours, they're going to need another CAT scan before you start them on the aspirin therapy. And if they're bleeding, give them FFP. So make sure you know who cannot get TPAs. Okay, after a stroke for 72 hours, they're going to be at risk for increased intracranial pressure. And I'm going to talk about this a lot. Okay, the normal value is 10 to 15. The first sign of increased intracranial pressure is going to be some kind of change in the LOC. They're going to be irritable. They can get downright belligerent. They can then start getting lethargic, right? So you're looking for that change in LOC. They may complain of a headache. They may get that nausea and projectile vomiting. They may have aphasia or other changes in speech. Pupil changes, they can have that too. Ataxia and seizures are other features they can have. Now, this Cushing's, triad, and posturing, these are, oh, here it is. These are late signs. So what Cushing's triad is the systolic blood pressure goes up, so it gets high, so the pulse pressure widens. Okay, so this semester we've been talking about all the conditions where the pulse pressure is narrow. This, we're going to be looking at widened pulse pressure. okay? They'll be bradycardic. Those are the signs. They're kind of opposite of shock, and those are late, not early signs. Okay, so pupil changes are going to occur on the ipsilateral or the same side of the brain injury. Okay. Um, in abnormal posturing, make sure you know the difference between decorticate and decerebrate. Okay. So decorticate, I always kind of feel like they're still trying to protect themselves by protecting their cord. Okay. Whereas decerebrate, they kind of gave up and they're extending now. So make sure you know which is flexion, which is extension. And then if you have a patient with a change in LOC due to increased intracranial pressure, you think it's increased, call your rapid, assess their O2 sat and their glucose, check their eyes, check their extraocular movements, check for any deficits, ask about a headache. Do not administer sedatives until they are seen by the provider. Put them in a quiet room, no TV, make it dark, no loud noises, no crazy family, dim lights. They really need to just chill out if you think anybody has increased intracranial pressure. The treatment of increased, or I should say the management, is monitor the ICP if they have some kind of device that you can do that. They'll be given osmotic diuretics, mannitol, and you're going to have to know the nursing implications of that. Corticosteroids may be given usually for brain tumors, but not for traumatic brain injury. Possibly, I haven't seen it given in stroke before, but usually brain tumor. Hyperventilate after the first 24 hours. Okay, so if somebody is intubated, they need to be intubated. One of the ways to increase intracranial pressure is to hyperventilate so they blow off the CO2. You want to make them alkalotic because CO2 is a potent vasodilator. So if the veins are dilating in the brain, they're going to have increased intracranial pressure. So you want the PaCO2 to be 30 to 35. Okay. That it's low, but it's not terribly low. Okay. They're going to need muscle relaxants, oxygen, and maintain the PaCO2 between 35 and 30 and 35. And you need an MAP greater than 70 to perfuse the brain. Now, in your management, this is just a picture of all the different kinds of drains somebody can have in like the neuro ICU. Okay, and some of them can, they monitor the increased intracranial pressure. They can also allow for drainage, so you can drain it if the ICP is high. But the most important thing is to make sure that you're practicing all the things you need to prevent infection, because if they get an infection, they're probably going to die. So you need to remember that it's reference. It's like hemodynamic monitoring is reference at the phlebostatics. This is reference at the lateral ventricle, which is really the tragus of the ear. So that's where you would reference this. Infection. So you're looking for meningitis, okay? So somebody has a drain. So remember the Brunitsky's and the Kerning sign. And then also, if the brain is irritated, they're going to seize, they'll have a high temp, they'll be confused and tired. And remember all those meningeal signs like photophobia, emesis, nuchal rigidity, nystagmus. Okay, so those are important. So to prevent increased intracranial pressure, head to bed needs to be 30 to allow for venous drainage, okay? And you need to keep the head and the neck in a neutral position. And sometimes if they do have increased intracranial pressure, you wouldn't let them use a pillow, okay? No hip or neck flexion, no clustering of activities, which is what we love to do, right? You can put oxygen on them, no seizure precautions. Make sure they're quiet, make sure the room is dark, make sure they're on colace, because you do not want them to strain, you do not want them to cough, you do not want them to sneeze. So hyperoxygenate prefers suctioning. Try not to make them cough when you do it. And then hypoxemia, hypotension, and acidemia worsen. They make ICP worse. That's why we make them alkalotic. And then with teaching your UAP, you have to tell them not to cluster the care, not to pull up if the patient has a weak flaccid side, never slide in the bed, because the patient's going to get a skin injury. So make them use a lift sheet, approach the patient from the unaffected side. And yes.
I thought that when a patient has ICP, one of the things that we weren't supposed to do was suction. That you weren't supposed to suction a patient with ICP.
You might have to if they're
Okay.
intubated, but you wouldn't
Okay.
let them cough.
Okay.
Yeah, you can't let them cough. Yeah, but you hyperoxygenate beforehand because hypoxemia can, create more increased intracranial pressure.
Okay. Thank
Um,
you.
that's okay. And then with feeding, remember no straws, head and neck forward, head to bed 90. Don't place them on their back and keep them upright for 45 to 60 minutes after eating. Um, Make sure your suction's ready in case you need it. And then the medications. Okay, mannitol is an all-time favorite, high yield NCLEX question. So make sure when you're giving this, use a filtered needle and use a filter on your IV. It's like an extra thing you have to get. Don't use if the solution has crystals. Monitor the CVP and wedge before and every hour during administration. That's because mannitol is an osmotic diuretic. So what it's going to do is it's going to pull all the fluid from the interstitium into the vascular space. So your patient is going to be at risk for like fluid overload. So you have to remember that. Make sure you're weighing daily. Do not discontinue abruptly because they'll get massive headaches. And usually it's given around the clock. Like usually when I've given it, we have an order to keep the osmolarity like 310 to 320. So you would check it before you give it. And you want to infuse slowly to prevent overload. Okay, everybody that has had like an ischemic stroke, they're going to be on aspirin or clopidogrel, which you don't give until after 24 hours after they've had TPA and a CAT scan is done beforehand. Um, and then if they had a hemorrhagic stroke or subarachnoid hemorrhage, they're going to get nimodipine or nicardipine. They will get nimodipine. That's the one that crosses the blood-brain barrier. Nicardipine if blood pressure is high, and stool softeners definitely need that. All patients should be going home on a statin. Do you guys have any questions about anything else, like burns? Have you had a chance to review it?
No, I don't think I have any questions with that one. I'll probably just re-listen to that one later on tonight and take some additional
Okay.
notes.
Okay, do you have any questions for me?
I don't have any questions right now. I might have some come Wednesday, but not right now.
Okay. Anybody else have any questions?
No, not right now. I'll just go back and look at the main points you talked about and that you emphasized for the exam.
Yeah, on burns?
One both on the strokes and the burns. I'll just review all that stuff.
Say that again?
So I'll go back and review the lecture from Burns, and then I'll look at your stuff that you emphasized tonight for strokes.
Yeah, definitely. And
There's,
then,
there's a
okay,
lot to
so
know.
so we have this week, then next week I'll do like a remote, right? Because that's before Thanksgiving. And then the following week, I'm just trying to map it out, like how much time we have.
I think it's like 3 weeks left, not including next week because of the holidays.
Okay.
'Cause then we had proctors, and then I think final exams right after that.
Okay, so do I have enough time to do I have enough weeks to do TBI and brain tumors and then end of life?
Yes,
I do have enough time? Okay.
yes.
I just want to make sure that I have enough time. Okay, with burns, okay, make sure you know how to classify a burn. Like you're going to have to know like um, airway stuff, but make sure you know the different characteristics of burn depth, okay? Because you'll get questions that'll be like, oh, somebody came in with partial thickness, superficial. What findings does the nurse like anticipate? Or they might say, this question might read, you have a patient with a wound that is red to white with slow cap refill. What kind of burn does the nurse suspect the patient has? Something like that, okay? So make sure you've got these locked in, these um, different degrees of burn, and we talk about them in these layers, right? Partial thickness, superficial, and don't get that mixed up with superficial. People do that a lot. Make sure you know with full thickness, we're worried about leather eschar, okay? Now, leather eschar can lead to two things. If it's on a limb, it could lead to compartment syndrome. So make sure you remember compartment syndrome is going to be the hallmark is they've got narcotics and it doesn't relieve the pain. You've done comfort measures, doesn't relieve the pain, but you're looking for also those signs of low circulation, like a normal pulse is +2. So anything less than +2 pulse is a low amplitude. Cool digits or cool toes, numbness and tingling, paresthesias. That's what you're looking for with those things. And Remember that. And then if it's on the chest and it's circumferential, they could have trouble breathing, and they'll probably be intubated if they have a big burn like that. And what you'll hear is the high alarms going off on the vent. And then the physician's going to need to come and do an eschorotomy on that. Remember, high alarms mean obstruction or the air can't get through, whereas low alarms mean the patient is not breathing at all. Make sure you know how to do the rule of nines. I think there are like 3 questions about the rule of nines on your exam. And then, you're going to have to know the difference between minor, moderate, and major, and the Parkland formula. So one of the most important things in the first phase, the the emergent phase, is fluid resuscitation. Okay, that's like the most important thing you got to get done. You got to get those 2 large IV bore IVs in so that you can give a lot of lactated ringers. All right, and you know what the goal urine output is. So make sure you know how to do that. And if somebody has an electrical burn, that's an electrical burn. You're going to get EKG.
So
Okay,
when did the language change from like the partial thickness to first, second, and third degree burn? 'Cause that was what I knew growing up.
first degree, second degree, third degree. That was when I was in nursing school.
Right.
We changed to this a long time ago.
Okay.
Yeah, and so I always go by like what ATI says because I mean ATI writes your NCLEX, so I'm always like I'm gonna go whatever ATI says we're using now. So that's why I teach it that way. Um, so with the pre-hospital care now, you're a nurse. People are going to be coming knocking on your door in your neighborhood, telling you they got burned. Okay, so you're going to have to know what to do for it. And so if somebody has like a minor burn, you're going to run cool water over the burn. That's what the answer is. Not put like butter on it. Not use any kind of ointments or anything. You're going to cool it like that. If you are involved in a fire and you go outside, do not run back into that building. It's not worth it. And we never immerse people that have had burns, okay? Because you don't want them to get hypothermic.
So why not water on the burn?
No, you do. You put it over the burn. You irrigate over the burn.
Oh, okay. I was looking at the
Yeah.
butter picture. Never mind.
You
Okay.
don't want to immerse them because you don't
Okay.
want them to be hypothermic. And then in the emergent phase, you are going to have to know all these, like what happens early in the resuscitation phase, these labs. So make sure you understand that. And then um, how to prevent ARDS, you're going to have to know that too because they get leaky capillaries, okay? So you don't let them get hypovolemic because that is a trigger for ARDS. So is sepsis. So sepsis we worry about more in the acute phase, okay? You want to make sure you're feeding them early. 2 reasons: to prevent ARDS, but also because when a burn, I don't know if I mentioned this, burn is trauma. They're like the universal trauma patient. And they have very high nutritional needs because their body goes into a hypermetabolic state. And that's, one of the reasons they're weighed every day too, is to make sure they're keeping a good nutritional status. But you have to keep them fed well. You give them those early enteral feedings so that they can hopefully you'll prevent ARDS in them. And remember your primary survey, all the things we do in primary survey. Okay, so airway, remember that is important to look for, and they need to be prophylactically intubated. They need to be, here's the espirotomy. So they need to be paralyzed and sedated. And then with preventing hypovolemic shock, LR is the fluid we use with the Parkland formula to give them all the fluid. Look out for the hot markers of high potassium, like the 1st-degree block, peak T waves. Electrical burns are going to be at risk for VFib for 24 hours after, and they may need mannitol. Any other type of burn does not get diuretics, okay? Only electrical burns get mannitol, and that's to prevent an AKI. Everybody that's had a burn is at risk for Curling's ulcer, so they are going to need some kind of prophylaxis. And they probably may get paralytic ileus. They're going to have high sugars, okay, because of the stress response, and watch their kidneys, watch the urine output. The room temperature needs to be 85 if they've had a large burn because the skin protects us from the cold and they don't have that protection anymore. So that's why you need to make sure the room is 85. Then with your enteral feedings, okay, remember you always check placement with the chest x-ray. That's the gold standard. Also on whatever, this is a NG tube, so there's markings on it. So you would report off to the nurse what centimeter line it's at, so that when they go in, they can check. And if it has a move, they can feel better about that. Make sure you know about the residuals. You'll be checking them about every 4 hours. And if it's more than half the rate, you're probably going to hold it. Okay. In the acute phase, we are going to worry about infection. The acute phase starts when the patient starts diuresing. So it could be 48 hours after, 36, or even up to 72 hours after. But what happens is in a burn injury, they have those leaky capillaries early on, right? So that's why you're dumping all this fluid in them, and it's going to leak into their interstitium because of the leaky capillaries. But it's the only way that you're going to prevent hypovolemic shock. So you have to give them a lot of fluids. And then what happens is the capillaries get a little bit better after 24 to 48 hours. And then the fluid comes back into the vascular system, and now they're going to start diuresing. Okay, so in this phase, we worry a lot about infection. So make sure there's no standing water around. Like you kind of treat burn patients like you would a neutropenic patient, like don't allow fresh flowers in the room, okay? Because that breeds Pseudomonas. So you would do that. I talked about the nutritional status, really important. If they lose 10%, the diet's got to be modified and they need a ton of calories. So you probably have to collaborate with a dietitian. Um, Also in the acute phase is when they have all the treatments like hydrotherapy, their dressing changes, whatever it's going to be. Okay, yeah, a lot of approaches to wound care. So the open method, that's usually done with the ointments. Again, the room needs to be 85. The closed method, that's just bulky dressings. Mechanical debridement, so they might have this like every day. It can be quite painful. So if they have PO meds, give it an hour before, and if they're IV meds, give it 30 minutes before, because what they do is they wash it off, but then they debride it with tweezers and scissors if the eschar is soft enough. And they use some of these enzymatic ointments, which can be painful. Okay, so with Silvadene, you're going to watch for neutropenia, and with Mafinide, you're going to watch for metabolic acidosis. And how I remember that is it begins with MA, so for metabolic acidosis. They can also get all kinds of biological dressings, skin coverings. They can have different kinds of grafts. The main thing about any kind of burn injury is that you don't want the patient to get contractures, so you do not allow them in a position of comfort. Like their joints all need to be neutral, okay, so they don't get contractures. And then in the last phase, this is the longest phase, it starts after the wound has closed, okay, and then it could go the rest of their lives maybe. But to prevent contractures, they use like these elastic type dressings that are going to be on like a Job stocking, and you want to make sure they're not out in the sun, and they'll be wearing this, like this could be worn 23 hours a day and it could be uncomfortable. So you have to encourage them to wear it. So those are the main points for burns. So early, it's going to be all about the fluid, right? Monitoring that, preventing hypovolemic shock, preventing ARDS. And then later in the acute phase, it's about preventing infection. And of course, the treatments, the dressing changes, etc. And make sure you know the characteristics and how to classify a burn with total body surface area, and the severity of the burns. Anybody have any more questions?
For the rule of 9, do we have practice questions on the
So
board?
where you can get practice questions on the rule of nines. Let me check. I think ABG Ninja has them, but so does registerednurse.com. Do you know her? The girl, the Southern
Yes,
girl.
Sarah, yeah.
I think ABG Ninja has it too. So those are some resources you can do.
All right. Thank you.
I'm trying to see if it's ABG Ninja. Yeah, ABG Ninja has the rule of nines. Here, I'll put the link right.
Eddie Ninja. Thank you so much.
Okay, here you go. Here's the link. Do you see it? So that
Yes.
has ABG Ninja, and also they have the Glasgow Coma Scale. Usually there's a question on the proctor about the Glasgow Coma Scale. There'll be one on your, we haven't done TBI yet, but there'll be one on your final too.
And TBI. Yes. Oh, 9.